marvellous. So high-risk women and unexpected admission. So just a quick, Kate's already done this, so I won't dwell on this, but this is the kind of ESC grading, if you like, of high-risk lesions. So there's high-risk lesions, and the next slide is very high-risk lesions, and the sorts of things that Kate's already mentioned, with moderate LV dysfunction, mechanical valves, some fairly complex congenital heart disease, which I won't go into, people who go around with low oxygen levels because of their heart disease, and a certain degree of aortic dilatation, which I'll mention later. And the sort of feeling is that these sorts of women are at increased risk of mortality or morbidity with a cardiac event rate of around 25%. Now, there are certain things that are considered to be very high risk lesions, so pulmonary hypertension, severe LV impairment, more severe mitral valve disease, or more severe aortic dilatation. And these are the sorts of conditions that if women have, really they should avoid pregnancy, and if they do get pregnant, then termination should be discussed with very high event rates. So rather than sort of try to come together with a bit of general advice on what to do if certain things present in local hospitals, what I thought I'd do was just try and select a few cases that we've had to admit over recent years, and I hope out of that some themes of the sorts of presentations and the principles of management will come out of that. So the first thing is aortic stenosis, and we have a fairly regular supply of women with aortic stenosis through the cardiac obstetric clinic. Congenital aortic valve disease is relatively common in the patients we see in the congenital clinic. So for those who are less familiar with cardiac anatomy, then this is a representation of aortic stenosis here. So this is blood coming into the left ventricle, pumped out to the aorta through the aortic valve. And aortic stenosis is a narrowing of that valve. And of course, if you've got a narrowing of that valve, what that can do is mean that it's difficult for blood to get out. And during pregnancy, more blood needs to come into the heart and get out of the heart. So the physiology of severe aortic stenosis is that you have this obstruction to outflow from the left ventricle, and that limits that ability to increase cardiac output, which is part and parcel of pregnancy. The left ventricle itself becomes thickened and hypertrophied, and that can make it more sensitive to drops in blood pressure. And if you drop the resistance of the circulation, then that can increase, if you like, the degree of sort of measured stenosis across that valve, and that can precipitate symptoms. And all of that means for a woman that there's a risk of heart failure, ischemia or lack of blood supply to the heart muscle, low blood pressure and rhythm disturbances. And then from a baby point of view, IUGR, low birth weight, preterm birth is found in around a quarter of those with severe aortic stenosis. What can you do about it in pregnancy? In some ways, not an awful lot, really. It's a fairly fixed stenosis. You can ask women to rest as much as possible. If you're really in trouble and the valve looks suitable, you might be able to blow a balloon up in it to relieve the stenosis to a degree, and that's something that we have done in the past. And then, of course, you get to the end of pregnancy and labour, and you have even greater demand and increases in cardiac output. And so that can be a time of even more risk. Epidural and particularly spinal anaesthesia can be a bit of an issue in terms of low blood pressure. And if you have severe symptomatic aortic stenosis, then this is one of the few conditions in which a general anaesthetic section is often the method of delivery. So here to illustrate that is a patient who, excuse me, was first pregnant a few years ago, 2017, 2018, the background of congenital aortic stenosis, which was severe. She did have a balloon treatment a good number of years ago, and she'd also had an ablation of an SVT in the past. And during this first pregnancy of hers, she's fairly easily breathless, but fairly late on, 34 weeks. So at that stage, she's advised to rest at home as much as possible. But she's seen less than a couple of weeks later, almost 36 weeks, and she describes a couple episodes of pre-syncope on minimal exertion. So she's not doing much, and she feels as though she's going to faint. And the concern about that is that effectively that's a reflection of a kind of limited ability to increase cardiac output. Even though you're not asking an awful lot of the heart by just walking around the house or whatever she was doing. So on the basis of those symptoms, that was a red flag, if you like, and she was admitted for bed rest and delivered by general anaesthetic section. Unfortunately, that was complicated by a significant PPH requiring a B. Lynch suture. But after that, she went back to her usual life. She works as a paramedic and went back to spinning classes, and we did an exercise test, and she did really pretty well on that. She could exercise for quite a long time. She had a reasonably good increase in blood pressure. So I was relatively reassured. But I wasn't too reassured by the symptoms at the end of pregnancy, but I was relatively reassured by her kind of cardiovascular reserve out of pregnancy, and thought it not unreasonable that she have another pregnancy if that's what she wanted to do. I seem to be stuck now. Hold on. Apologies, if you're all still there, my computer has completely stopped.
Yeah,
we're with you.
We're still here.
Okay, I'm just going to have to try and quit. There we go, fine. So she does get pregnant again, actually pretty quickly after I said I thought it was reasonable. And this time she's more symptomatic earlier on. So she's a little breathless at 13 weeks. She's also got a bit of asthma and seems to be a bit better with an inhaler. But at 20 weeks, she's breathless going upstairs. It's definitely not better with any salbutamol. And at this stage, she has some quite concerning measurements on her echo. And I know there's not many people who are cardiologists out there, but effectively we kind of measure the degree of aortic stenosis using the speed of blood through the valve, and it goes up quite a lot. And these are quite alarming figures. Doesn't mean the degree of narrowing has changed, but it's a reflection of blood flow through a narrowed valve. Having said that, at the time we did a blood count and her neutrophils were high. There was no obvious source of infection, and at that, but that may be something else was going on there. Palpitations, she also described 30 to 40 seconds. Remember, she had this background of SVT and she was started on some bisoprolol. And she's asked to then rest as much as possible because she's still only 20 weeks. She's not yet at fetal viability. 24 weeks, she's even more breathless, including at night. She felt dizzy after going upstairs, still getting brief palpitations, and she started on a bit of furosemide. And once again, the management really was emphasising the importance of rest, and at that stage, she stopped work. Just a couple of weeks later, she sort of contacted us to say she was feeling really very anxious about things, and she wondered whether some of the symptoms could be related to that. Particularly anxious when she got when it all got quiet at night, and she was thinking about what was going to happen for the rest of pregnancy, and possibly slightly less breathless. Echo maybe not as alarming as it was a few weeks previously, and then. A couple of weeks later, she's admitted with dizzy spells, one following an episode of palpitations, but admitted to not taking the bisoprolol we prescribed earlier in the pregnancy. So she was observed for a while as an inpatient and then discharged. But obviously, this is all quite nervous, really, because these are all symptoms that sort of are reflective, potentially reflective of her severe aortic stenosis. At 30 weeks, she has similar exertional symptoms, but she complains of things like being tired, brushing her hair and cleaning her teeth. And clearly, we're not going to put those sorts of things down to limited cardiac output. And at that point, she expressed a desire to have a section awake. We had a bit of a discussion about that in clinic. From an anaesthetic point of view, it was felt that might be reasonable. It does cause a little bit more vasodilatation than a general anaesthetic, and that can be difficult to deal with in the setting of aortic stenosis. But there was this thought that the GA may have increased the amount of postpartum hemorrhage that she had because of its effect on uterine tone. So that risk might be lower. At 32 weeks, she has stable symptoms and echo, and we had been planning for her to come in for routine bed rest because of the level of symptoms she's had. But this was just at the start of COVID, and the feeling was that she's probably better out of hospital than in hospital at that time. And at 34 weeks, she's even more breathless, and she's really struggling to rest at home. Her echo is quite concerning. And we're starting to get concerned that there won't be an ICU bed because they're filling up rapidly. So she's admitted for a GA section again, and that's performed in her case in cardiac theatres. and then she goes off to cardiac intensive care for that level of expertise and cardiac monitoring. Cardiac theatres, because should things go south during the section, she's in the right place potentially to have cardiac surgery if that's required. But actually, in the end, it was uneventful. And she's not planning any more. Well, I don't think she's planning more children yet. And she's now on the waiting list to have her aortic valve replaced with a sort of form of biological valve. So that's aortic stenosis. This is a case that illustrates cyanotic heart disease. So cyanotic heart conditions are those in which blood is that the heart condition itself causes the levels of oxygen in the body to be low and people to look a little on the blue side. You've got a video here of a complex heart. So this is a heart that's only got one pump where it should have two. And what it means is that oxygenated and deoxygenated blood all mix in here, and what comes out to the body is low in oxygen. And pregnancy and cyanotic heart disease can be a bit difficult. So there's a high rate of maternal complications. And in terms of fetal outcome, that very much depends on how cyanosed the mother is. So if their resting saturations are greater than 90%, then there's a pretty good chance that the baby will be okay. But if they're 85% or less, then there's very little chance that the baby basically will get enough oxygen to reach viability and good growth. So outcomes are poor. So this is all illustrated really quite nicely by this, at this stage, 23-year-old who has this complex heart. You don't need to worry about how it's all conformed. But basically, she had a miscarriage in 2007 when she was 24 weeks. And at the time, her saturations were in the 70s to the low 80s. So below that threshold that we would expect her to be able to carry a baby to fetal viability. And so really no surprise that she has a miscarriage at that sort of time. But then she has some treatment, which is basically a connection between her aorta and pulmonary artery, and that improves blood flow to the lungs and improves her oxygenation. So she now has saturations at rest in the mid-80s. So around that point where you might be able to, a bit more likely that a baby will be able to continue to grow. She also has other issues with her heart. Lots of discussions about how pregnancy is best avoided and methods of contraception, but she did become pregnant again. And at 20 weeks, I saw her, and the baby was very small for dates. I thought about it, but didn't admit her at that stage. And then we saw her again 4 weeks later. And even though it was small at 20 weeks, it hadn't grown any further at 24 weeks. So at that stage, she was admitted for bed rest. Bed rest means that her oxygen levels won't sort of go down further with exercise and oxygen. Now, oxygen doesn't change the oxygen levels, if you like, of a patient like this very much, but it does a little bit. And basically that combination was good enough for the baby to get some oxygen and to start to grow. But she then actually had an abruption at 30 weeks and needed an emergency section. Had a very tiny baby, but actually had an uncomplicated neonatal course and did very well and continues to do fine. In terms of unexpected admissions, I think this was the only one that I could, racking my brains, I could remember. So this is a 28-year-old who was born with pulmonary stenosis and an atrial septal defect. So pulmonary stenosis, this is an illustration of this. She's got this blood coming into the right side of the heart, the right ventricle, out through this narrowed pulmonary valve to the lungs. She then has a treatment of that when she's a baby, to have a balloon inflated in it to open up that pulmonary valve. That's called a pulmonary valvuloplasty. And then later on, when she's 18, she has the hole between her two atria closed with a device. So this is an atrial septal defect device, so closing the communication between the two atria. But actually, that's an incomplete procedure, and she still has a little bit of a hole between her right atrium and her left atrium. And blood flows across this both ways, but usually we don't see blood flowing from the right to the left. Because of her heart, other features of her heart, in her case, sometimes it could flow from right to left. So she became pregnant in 2017, and that was a successful pregnancy. But because of this potential right to left flow through the atrial septum, she was given some prophylactic low molecular weight heparin. And that's because we're a bit concerned that if there was a clot a sort of a venous clot that found its way into the right atrium. It could find its way across to the left atrium and cause a stroke or a heart attack. But that was fine. And then she comes pregnant again in 2020, and once again she's given prophylactic low molecular weight heparin. But on this occasion, when she's 32 weeks, she presents to a local hospital with a non-ST elevation MI at 32 weeks. She has a coronary angiogram, which is normal. Luckily, this MI doesn't have any effect on the ventricular function. And so the mechanism here is very likely to be a coronary embolus. So a little bit of a clot go across here and then out through the aorta down a coronary artery. And actually, she then admitted to missing doses of her low molecular weight heparin. She was struggling to tolerate it. So it sort of all fitted together, really, that she could develop a clot that could cause a systemic embolus. And she was treated with then treatment dose low molecular weight heparin for the rest of pregnancy and was fine. We've mentioned already a little bit about the dilated aorta and how that can be present very significant risk during pregnancy, particularly in the last trimester and the early postpartum period. And just to illustrate that, this was a 42, or still isn't, well, she's not still 42, but she's still around, 42-year-old patient with Marfan syndrome, 4th pregnancy. Previously, they were uncomplicated. She had moderate aortic dilatation. So her aorta, just as it leaves the heart here, this is just above the aortic valve, was 42 millimeters, and that had been stable for a while. She wasn't at this stage known to us until this pregnancy. She was taking atenolol, which is the sort of drug that we would use, or a beta blocker we would generally use in pregnancy to help reduce the risk of dissection. And she was delivered by an uncomplicated elective cesarean section. And one of the principles of management of patients with significant aortopathy is we tend to keep them in hospital for a period, often 5 days, really because that's a particularly high risk time of dissection if it's going to occur. And so if it does occur, they're in the right place to be treated. In her case, the atenolol was stopped a few days postpartum because her baby had an unresponsive episode and there was concern about there being a link, which is probably pretty unlikely. And then, of course, the day after she's discharged, having kept her in for 5 days and stopped her beta blocker, she has a dissection. So she has a type B dissection. And you can see the dissection in flap in her aorta down to here. So in her case, that was treated conservatively, and I think has continued to be, and she's been all right living with it. I suppose it's almost impossible to do a high-risk talk without mentioning mechanical valve replacements, because they really don't go together very well. And that's because if someone's got a mechanical replacement heart valve, that can develop a clot. If you develop a clot, that can be serious because the valve might not work very well, or bits of clot might fly off to places where you don't want them to go. You put that in a setting of a prothrombotic state, which pregnancy is, and then you add in the fact that warfarin, which we use to thin the blood of patients with a mechanical aortic valves, isn't good for a developing baby. Of course, you can use heparin, particularly low molecular weight heparin, which doesn't cross the placenta, and so it's fine for the baby. And unfortunately, that's not as good a blood thinner. And of course, you have to have blood thin, and therefore you must, almost by definition, increase the risk of bleeding. So a couple of cases just to illustrate that. This patient had a mechanical aortic valve replacement a good number of years ago in 2002 for congenital aortic valve disease. She, in 2009, she was 25. She was enjoying her life. She was on the progesterone pill. She wasn't necessarily taking a warfarin as she should. Her control was all over the place. She was drinking lots. And of course, there was a conversation about the risks of pregnancy. But just a couple of months later, she presented with chest pain to her local hospital and had had an inferior myocardial infarction. Now, we hadn't been told, but she was at that stage 7 weeks pregnant, and she'd known for a couple of weeks. And her local hospital had converted her to low molecular weight heparin, but actually without checking the levels of factor anti-10A. So that's something that we're absolutely obsessive about when we switch patients to low molecular heparin in the setting of a mechanical valve, with fastidious attention to making sure we've got the dose right. And so she then has an echo at the point that she comes in with an inferior MI, and there's a thrombus, a clot on her aortic valve replacement. So there's a discussion about whether it's really sensible to continue on this pregnancy. She's only 7 weeks, but she declined termination. We advised warfarin as the best anticoagulate, even though that would be a high-risk time for warfarin in terms of its effect on the baby. But she elected to stay on low molecular weight heparin until 14 weeks, and then she did then convert to warfarin for the remainder of the pregnancy, and it was fine. She became pregnant again in 2015 and was appropriately converted to low molecular weight heparin, and then at 12 weeks she coughed, and the cough seemingly caused her to have this massive pelvic hematoma, which looked like it was from a rectus sheath hemorrhage. And this presented a major problem for her because it meant we had to completely stop anticoagulation because she'd had such a major bleed. And in fact, that hematoma required drainage via a laparotomy. And sort of unsurprisingly, she then probably developed another thrombus on her aortic valve replacement. But luckily, all of that did settle down. And then she came for a routine review, an echo at 31 weeks. And this is an echo showing that she has then once again developed what we think is a further new thrombus on her aortic valve replacement. So she's admitted, but actually then goes into spontaneous labour. I think it was the same night, and delivered vaginally at 31 weeks. And it all had a happy ending. And then her partner had a vasectomy, which was good for all of us. And here's another mechanical valve saga. So background of mechanical mitral valve replacement for endocarditis back in 2013. 4 children prior to that valve replacement, not someone we knew. And then she becomes pregnant in 2018. Again, not great compliance, hadn't taken warfarin for 4 months prior to her pregnancy. She initially decided on terminating that pregnancy, but then changed her mind and was started on low molecular weight heparin, but didn't come to clinic, didn't necessarily take a low molecular weight heparin. And at 23 weeks, presents with a thrombus on her mitral valve replacement. And that thrombus has caused it to become very narrowed, so it's very stenosed. So that's very concerning. She's got fresh clot on a valve, and blood's finding it difficult to get through the heart. So we talked about what we were going to do with this. We even considered thrombolizing her. She was clinically she was clinically stable despite this appearance on her valve. So she was treated with intravenous heparin, not something we do very often, and then converted to warfarin and aspirin. And that clot appeared to resolve completely as far as we could see. And then she's admitted electively at 35 weeks to convert her to heparin. So that's a little earlier than we would normally do in a mechanical valve. But of course, she'd been through this severe this episode with extensive clot on the valve. So we initially planned for IV heparin, but the haematology advice was that wouldn't be great. We were going to try and do this for around 2 weeks before we delivered her. And that's difficult to get right for 2 weeks. And that, in fact, although I wasn't something I was aware of, APT doesn't necessarily reflect the anticoagulant effect of IV heparin late in pregnancy for various biological reasons. So she was converted to therapeutic tenzaparin with regular anti-10A levels. And then at 37 weeks, there's a possibility of her going into labour. So in fact, at that stage, she's converted to unfractionated IV heparin. So it's got this rapid offset should she be going to established labour, and ends up having a straightforward vaginal delivery with a gradually increasing dose of tinzaparin postpartum, which is fairly standard for us after a mechanical valve patient has delivered. And restarted warfarin quite early, 3 days after delivery, because obviously you're always balancing the risk of bleeding versus the risk of valve thrombosis. And in her case, the risk of valve thrombosis was greater than most. But the valve function looked okay postpartum. So then she didn't attend multiple clinic appointments after that pregnancy. She was actually booked for a sterilisation in her local hospital, but it wasn't done because she was pregnant again, although she miscarried on that occasion. She then presented to a local hospital in January 2020 with chest pain. And she told the medical team when she presented that she thought she might be 6 weeks pregnant. And then she had a scan which showed that she was, well, they initially thought 34, and we subsequently decided around 31 weeks pregnant. And then she admits that one of her children had been asking her why she was getting fatter. So initially she was converted to low molecular weight heparin, and her echo initially looked okay. But 10 days later, we saw her again, and it had changed quite dramatically. There was a high gradient across the mitral valve replacement, and so it looked very likely that she developed new clot, an extensive clot on that valve. And so in this situation, we're really concerned, she's getting to the point of delivery anyway, we're really concerned that any period off anticoagulation, which is mandated to deliver her, would be exceptionally high risk. So we've not done, well, I certainly haven't seen this before in my career and hope not to again. So she underwent a single operation where she had a cesarean section, a surgical sterilisation, and a redo mitral valve replacement, all in one go. And then she hasn't come back to clinic since. And then just to leave you with these images, so this is the intraoperative appearance of her mitral valve replacement. So this is the surgical view, and you may not be familiar with mitral valves, but this is a really, there's a lot of tissue tissue and clot around this valve, and this orifice is really quite small, looking down on the valve. And then this is the explanted valve. And this sort of pearly white here is what's called panna. So this is tissue growth, which is a chronic tissue growth that's restricting the orifice of the valve. And these are bits of fresh thrombus on the valve, but that's much less extensive than what was present originally. The surgeon's already taken loads of that away. So it was absolutely the right thing to do to take that valve out at the time, even so that's obviously a very dramatic thing to do. I haven't really got a way of summarising all of that, but hopefully that's given you a flavour of some of the sort of acute admissions or some of the acute presentations and the sort of principles of management of them.